The broadcast is now starting. All attendees are in listen-only mode.
Welcome to today's session entitled Conversations with GIA, COVID-19 in Rural America, How Can Philanthropy Respond? Before we get started, I'd like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. John?
Thank you, Tracy, and welcome, and thank you for all of you who are joining us today. We also want to thank the John A. Hartford Foundation for their support of today's webinar and our entire GIA Conversations with GIA webinar series. During this time of tumultuous change due to COVID-19, our attention has often turned to the places in which the crisis first appeared, urban hospitals. Lost in most of the news coverage has been the growing impact on rural areas of the United States. Rural America is older and has a more fragile health delivery system, including aging services. The impact of the virus may be eventually more dramatic than in urban areas, especially for older persons. Today, we will talk about several aspects of the pandemic, including a national overview of how philanthropy in rural America is responding to COVID-19 with new initiatives and more flexible processes. A report from a regional funder in Central Texas on their role in rapidly expanding and coordinating local resources in a rural county to meet the needs of older persons. And then as a response, the person who is providing those services to older persons and can talk more about what they're doing specifically around COVID-19. And finally, the impact of new and more flexible regulations for telemedicine during the emergency and implications for rural areas being able to provide expanded services. I am really happy that we have national experts on all of these issues, and that includes Alan Smart, who is advisor to philanthropy at Philanthropy Works, Abana Asante, Senior Program Officer at St. David's Foundation in Austin, Texas, Debbie Bressett, the Executive Director of Bastrop County CARES, and Dr. Darren Anderson, Vice President and Chief Quality Officer at Community Health Center Incorporated. We want to thank you all for being with us. As was mentioned earlier, you can enter your questions for our panelists at any time in the question box on the right-hand side of your screen. I will collect these and read them to our panelists during the question and answer period that will follow all their presentations. Alan, let's start with you. What are you hearing on the national level about what philanthropy is doing for rural areas during COVID-19?
Well, thank you, John. Thank you and greetings to all the rural interested funders and advocates out there. And many thanks to Grantmakers in Aging and their ongoing recognition that rural America merits a distinct look from the philanthropic lens. I've been at this work for about 20 years. And before we get into the substance of today's discussion, I wanted to recognize a relative newcomer to national leadership for rural communities, and that's John Feather, our GIA leader. John, as many of you know, will be retiring from GIA by the end of the year, but has become a key spokesperson for one of the sectors that much of philanthropy seems to forget, which is rural older adults. Through the recent work on opioids and transportation, John has built a community of funders that will carry on well past his GIA tenure. And hopefully, he has provided a path for other national funder groups to deeply engage in many other aspects of rural work. So thanks so much, John. We have some great presenters coming on in a few minutes, but I've been asked to frame the discussion for both the veterans and the newcomers to rural philanthropy that we would have on the call. And first slide, please. So it's always worth pointing out there are about 60 million rural folks in the United States spread out throughout the country with tremendously different cultures and histories. different economies, some thriving, some suffering pre-COVID-19, and all of them impacted in unique ways now. There are rural regions in every state, which may surprise many. There is, in fact, a federally funded Office of Rural Health in every state. And importantly, rural funders in every state, many legacy family funders, but hundreds of newer or newish healthcare conversions, and thousands of rural serving community foundations. Could go to map 2, please. There are 13 million rural people of color in the United States, belying much of the mythology of what rural America looks like. Some who have predate the United States by literally thousands of years, and some part of the 2 million immigrants that live in the rural United States currently. While rural people of color are slightly older in the South and slightly younger in the Southwest, I think you can use this map as an approximation of where rural and older adults of color live, which I think is particularly important in the midst of COVID-19. We could go to map 3, please. And as you may have heard, rates of COVID-19 are rising more quickly in rural than in urban areas. The trend is expected to continue. The impact on rural communities of color in the Southeast and among Native Americans is profound and disproportionate. Next, please. And one of the questions would be why? Well, we certainly have a number of groups. These are just 3 who are at greater risk, who are specifically tied to rural America. Native Americans, prison and jail employees, meatpacking and processing workers, and as I said, all people of color living in rural America are experiencing disproportionate risk and prevalence of COVID-19. Next, please. So many of the standard funder responses that have been promoted on a national, regional, and local level, you see 4 represented here: relaxing reporting requirements, paying forward existing obligations, converting program grants to general operating support, contributing to funder pools. All fantastic, all should be considered in light of your individual funders' history and kind of mindset, community interaction, formal versus informal, and there's a long list of other, I think, kind of grant administration related responses that would provide value to many grantees and many nonprofits. But and if we'd go to the next slide, I would vouch to say that if you are a rural interested funder, whether currently engaged or seeing a need or a gap that you might seek to enter, these types of grant administration fixes or amendments are not enough, and it certainly speaks to the neglect of philanthropy over the years in rural America, but also the leadership opportunities that are presented in the midst of a crisis like COVID-19. Next, please. And one of the barriers, of course, is that certainly still in some parts of the country, and some of it's regionally specific, but some of it might be county specific, the numbers are all subject to question given they're often dependent upon the availability of testing. But the case numbers in many rural counties are still, at least in terms of absolute terms, quite low. There may be 10 or 20 or 30 cases. But I think it's important to point out that while 50 cases doesn't sound like a lot in the gross sense of things, in a county of 25,000 where there's closed schools, workplaces, and nonprofits struggling just to adjust to current conditions, it is a lot. And who knows what's coming next, and the impact on community, certainly in consideration of the many barriers to healthcare access, to nonprofit stability that existed well before COVID-19. The impact on rural communities and the opportunities for rural funders are, kind of at the perfect storm of both challenge and opportunity. I think it's important to say, though, there are certainly rural regions of the country that are deeply impacted in ways that reach a national level think there's been a good deal of attention paid to the areas around Albany, Georgia, and the southwestern part of the state, Native Americans and tribal communities in New Mexico and Arizona, almost beyond comprehension, the impact, and still not meriting kind of the national attention they so both badly deserve and badly need. So if you want to go to my last slide, and we'll get to a little more of the tactical piece that I hope is both reflected in some of the discussion forward, but gives people at least a tip or two. So over the course of the last 6 weeks or so, I developed a blog that came out last week for the National Center for Family Philanthropy, which really sought to take a look at a number of rural funders, but highlighted 4 individual rural funders, all with long legacies in their communities, all family funders, given Heritage National Center for Family Philanthropy and their membership. And all in both different geographies, different size, different economic and kind of cultural contexts. But I did want to put forward at least a number of kind of tactical perspectives that one might consider, that at least one, and often all of these 4 are either implementing or considering. So one thing we know certainly is there's a lack of accurate information on a local level, and that would be true of any news that has local implications, the demise of local newspapers, local radio, the syndication of much of the information from national sources. So funders are certainly looking at how to disseminate. Could be as simple as a Facebook platform, how to disseminate accurate information that is local, culturally appropriate, gets people where they're at, and makes sense in terms of both preventive activity as well as positioning for the future. Many funders, certainly, whether it be national, regional, local, have board members scattered across the country, and there's not a natural or organic way that they're going to get information on what the local conditions are. So all of these funders are spending a good deal of time really keeping their board members apprised of what is the current state of things re-COVID-19, when there may be only 15 or 20 or 30 cases, but the communities are being fundamentally challenged. Clearly, the closing of schools, the ability to apply for unemployment, the ability to contribute to the census, whole number of things going on concurrently, that the deep inequities around rural broadband access are becoming even clearer. Official numbers say there's 20 million rural Americans who have no access to broadband. The real number is likely, based upon some kind of testing that was done a couple months ago by some independent sources, real number is probably about 40 million. So just imagine the impact on local schools. So there's a number of innovative ideas these funders and many other rural funders are taking a look at and implementing and supporting in terms of allowing access for broadband. Think of all the libraries being closed when in a rural school district that may be the hub for broadband activity. What are creative ways to check in on isolated older adults? A number of these funders, as well as certainly others in the field, are taking a look at what are some basic mechanisms just to pay attention to the fact that more older adults live alone in rural America than in urban or in suburban, and how do we try to shore up that system? PPE is still difficult to get. There are rural hospitals, unimaginable it may be, but are essentially on their 3rd or 4th workaround to access basic supplies. How can a funder open doors, for example, to a local manufacturer or some kind of access system that the hospital or the healthcare or nursing home wouldn't be able to on their own? Please be advocates, both for your communities and both locally, in terms of making that phone call or calling that virtual meeting. to get people's attention in ways that the average nonprofit can't. And that's often the power of rural philanthropy, is the ability to open those kinds of doors. Represent rural and regional and state commissions. Certainly whether it's specific to your county, Lumpkin Family Foundation, Bruce Carmazan, who's the ED there, he's on a statewide commission really, and his role as he sees it is to really say, hey, let's not forget rural communities in the midst of COVID-19, even they don't have these huge numbers of cases at this point. Many rural funders pride themselves on being incredibly relational. All these rural funders would say they spend all their day on the phone talking to grantees, nonprofits, community leaders, and in some cases listening, in some cases acting very quickly. But the personal contact that a rural funder might have has been, and the positive role has really been exemplified, the need for that in the midst of the crisis. And I think maybe most important of this list in terms of strategy for a funder and what I see effective rural funders really doing is, you may be the only entity of a leadership, from a leadership sector or having a leadership position to actually be looking down the road, as everyone is consumed with the urgent demands of schools and healthcare and economic distress and all that goes on with all of that. But what's the positional leadership role that you can really either assume or help people support other people in looking that 6, 12, and 18 months down the road? So that's a very short list. As always, certainly I'm sure people are positioning questions, but I'm happy to respond to people offline as you want to get networked with others or want to learn a little more about some of the things I've spoken about. So now I'll toss it over to Abena Asante at the St. David's Foundation from Austin, Texas, and look forward to hearing you, Abena.
Thank you, Alan. Hello, everyone. Thank you for the opportunity to hear a little bit about what one regional funder in Central Texas is doing to respond to COVID. So I'll start by sharing some comments and then invite my colleague from Bastrop County, Debbie Brissett, who can provide some on-the-ground accounts of what they are doing to pivot to respond to older adult needs in Bastrop County. So let me provide a little bit of a context with about St. David's Foundation. We fund in a 5-county area in Central Texas and invest over $70 million in this area. And we are guided by 3 strategic priorities. Tracy, could you advance to the next slide, please? Our work is guided by these 3 big buckets: healthiest care, which is work focused on the safety net, health care, primary health care, the workforce, specialty care. Then we have healthiest places, that work focuses on actual places. And so the rural communities bucket of work falls under the healthiest places. And then we have healthiest people. And for the purposes of this conversation, I'm lifting up older adults aging in place, which sits right under that bucket. Could you advance, please? Great. So just drilling down on the rural communities goal area, the key words here for our goal is co-creation solutions with the community that are place-based and are community-led, and that will address prioritized social determinants of health. So how do we do this work? We are guided by 3 approaches. We see the value in community engagement and empowerment, and so supporting interventions that strengthen ongoing relationships and networks in the community so that they can address community-inspired challenges in their own way. Another critical area that we invest in is around building capacity, and that's a big umbrella. So building capacity of the people on the ground doing the work, the formal and informal leaders, building capacity of nonprofits and other non-traditional partners involved in this community change efforts to improve the health and well-being in the community. And then the third approach is around the foundation investing in solutions that build on the community's assets so that the ecosystem for change could be developed and help the community address rural relevant approaches that make sense to them. Next slide, please. Okay. So the lay of the land in Texas, we know that Texas has the highest uninsured rate in the nation, and Alan commented on the rural hospitals. We have our rural hospitals closing at an alarmingly high rate, and the ones remaining are not operating at an optimal capacity. We also know that the population is older and sicker. The broadband issue exists, and there's this question around broadband no longer being a luxury and that it is a utility. And I would even go further to say that it is a public health necessity in this case of COVID and what else comes up. We've also seen the data changing here in terms of rural beginning to show an uptick in infection. In Texas here, we have a low testing rate, and what we have been grappling with my colleagues as well as other funders is relating to the implication of relaxing the lockdown policy coupled with the rural rate increase. So that is something that we have to look at critically. And finally, the impact on communities of color here. When you look at Travis County, where Austin is, 51% of all the hospitalizations due to COVID are from the Latino community, and they make up just about 34% of the population here in Travis County. African Americans, all hospitalizations, about 34% or so, and we make up about 8 to 9% of the population here in Austin. Next slide, please. Okay. So the key takeaway that I want you to take from this slide is that when you look on the extreme right, we have the 5 county areas that the foundation invests in, and those numbers embedded within the counties are the county health ranking rate. So Bastrop County is 79, and Caldwell County is 146, using the 2019 county health rankings number out of the 244 counties that are ranked here in Texas. So you can tell that there are opportunities for improvement. And so how can philanthropy engage differently with these communities to help improve their health and well-being over time? We know that relationships matter big time in the work. We spend a lot of time doing listening sessions, field visits to Bastrop County. We also build on our earlier relationship and investment in our footprint relating to Hurricane Harvey in 2017, supporting the small mom and pop shops, the faith communities, and other groups that were on the ground providing immediate relief support to communities impacted. In our own work as a funder, we've done a lot of programmatic investments around supporting nutrition, supporting intergenerational efforts, and also Capable, which is a project that allows for a nurse, an occupational therapist, and a handyman to visit the home of an older adult and then conduct an assessment and provide some fixes that would allow the older adult to live in place successfully. And then out in Bastrop County, another thing we've been doing is around network weaving, leadership training, which has allowed about 25 weavers from the community to go through a 9-month community of practice and training to learn about the principles of network weaving, which they are using to think about how they can address their most pressing and challenging issues and how they can build connect across divides within the community. In partnership with Texas Rural Funders Collaborative, we've partnered with Catch a Fire, which allows nonprofits to receive virtual skills-based expertise from volunteers on an X issue. And also with Texas Rural Funders Collaborative, working very closely with Connected Nation around how the broadband gap could be addressed here in Texas. And so all this is being said with a lens that relationship trust building is key in order to get any of these work that I've outlined going on. Next slide, please. Okay. So what are we doing here at St. David's Foundation? So back to what Alan mentioned in reference to standard response to COVID that funders are doing, we are converting our current grants to general operating support. We did that, and about $16 million were converted into general operating support. We also worked with community partners to deploy surveys. One survey, for example, was with a group called Mission Capital, where they surveyed about 450 nonprofit organizations and about, can you hear me? Hello?
Yes, we can.
Yes. Great, okay. So Mission Capital did a survey of about 450 nonprofit organizations, and about 80% of them already had experienced significant disruption in terms of their services to clients or communities by April 1st. And 1/3 of the respondents also mentioned that they did not have enough funds to operate beyond 2 to 6 months. So I'm saying all this because this helped inform St. David's Foundation's strategy in terms of how we respond to COVID. Another nonprofit that we partner with called Measure, what they are doing is doing surveys designed by people of color for people of color to capture the lived experience of residents in the 5-county area, so that could also guide philanthropy and other public entities relating to shaping a response for these members. We are part of a funders pool with Austin Community Foundation and United Way, and they've been great partners when we did the census work. And I think what is key here on this slide is that we are nimble, so we are continually having ongoing dialogue with our community members as well as grantees. In a recent conversation with a grant partner that works for a housing authority, he had to transform their role from quote unquote collecting rent to being proactive and reaching out to older adults in their community to provide groceries and also medicine and other services to ensure that their needs are being met. Next slide, please. Okay. So here are my final thoughts. Funder flexibility is key to this work, but I think what is really important that has to be lifted up is the fact that what we learn on the ground has to be translated and shared with our board, who make the decisions relating to the direction of the foundation. And also talking about flexibility, it's important that we are flexible beyond just the grant making and to think about other ways in which we can support our nonprofits and communities navigate COVID. I came across a piece by the Whitman Institute titled Principles of Trust-Based Philanthropy, which is around the importance of funders in this time of crisis, even more highlighting the importance of trust and collaboration, and that it's important that as we do this work, the 6 principles that guide trust-based philanthropy is emanated. One is around providing multi-year unrestricted funding. Another one is being transparent and responsive to the nonprofits and community, being authentic in how we streamline and solicit feedback and acting on that feedback, and also not creating any burdensome reporting or paperwork when we know that all the nonprofits are hunkering down to pivot to respond to the needs here in their community. And finally, we are thinking about ways in which we can offer support beyond the check. And so how do we amplify those stories that are coming up from our nonprofits and the communities impacted? Who can we connect them to? How do we leverage our social, reputational, financial capital to support our communities? Another thought that I'd like to lift up is around philanthropy's role in advocating for some of those temporary policies in place now. How can we help in making those policies permanent? For example, telehealth. We hear a lot from the rural areas that telehealth is the problem. And with COVID, CMS is now reimbursing for telehealth in certain areas. And so what can we learn from this effort, and how can we ensure that those quote unquote temporary policies become permanent, because it's part of good health? And a final thought that I would like to lift up is around the system inequalities and inequities. We know that marginalized communities, even before COVID, were impacted with so many multiple health and social issues. COVID just amplified it. And so how can philanthropy use this moment to change our approach in terms of how we fund and how we show up in working with marginalized communities? And with that, I'd like to invite Debbie Brissett with Bastrop County Cares to share some reflections on what's going on the ground with Bastrop County. Debbie?
Thank you so much, Abena, and thank you all who are listening to this. Abena and I are experiencing incredible storms here in Central Texas.
Yes.
All morning we've been surrounded by tornadoes. So I just wanted to say thank you all. It seems so calm on this call. I also want to just say this has been an incredible experience for Bastrop County. When Abena first reached out that she was interested in talking to us, to Bastrop, I didn't realize that it was going to begin a path that we would walk together for the last couple of years. And we changed both who we are and how our organizations work. You know, when I first spoke to Abena, I was like, I don't want the foundation to be about the money. You all have so much more you can offer us as a county. I wanted them to be a thought partner with us, to help us figure this out together. I wanted them to be a research partner to help build the capacity to bring research and new ideas. And I wanted them to help us be innovative in our thinking. We were a very young nonprofit. We partnered very closely with our county and our city. And we were really poised to want to do things differently. We built out coalitions made up of just regular old community members around issues and things that they're passionate about. And so we decided, Abena and I, that before they really funded much else in Bastrop County, because they've been funding programming, right, for a while, that I wanted them to do a tour. So we took this incredible tour on our rural carts bus our transportation bus, and we had a historian who's also our bank president. We had our county judge with his big old white cowboy hat, and we had our chief medical officer, a beloved doctor in our community. And we toured through 2 of our precincts in Bastrop County, Precinct 3 and Precinct 1. And they got to see the Spanish, where the Spanish land grants were, where the freedom colonies were. We toured through some of our marginalized and most disenfranchised parts of our community. We had a history lesson. We had, and we toured deep pockets of poverty. We had St. David's Foundation board members, we had their executive staff, and we had community leadership on that bus, really to see what it looks like right outside of Austin, Texas. And then St. David's Foundation, we set up listening tours with our leaders, our elected officials, and our leaders who sit at a different perch, with our nonprofit community, and then also with people in the community. They met at our schools and in community centers across our county. We had organized to attack large community challenges that not one single organization can solve on its own. And so we pulled together coalitions of people. We have our owls. Abhinav mentioned that. That's our older, wise leaders. And they did not want to be called seniors. And it's people in the community who really care about issues of aging and aging in place and aging well in place. We have a very fast growing population of our owls in our community. We also have early childhood, human trafficking, we've got workforce issues, workforce housing issues. So we have a variety of things that we're coalescing around. And while we were doing that, we were pulling what people were saying in all these community meetings, and that's where our coalitions came from. And as Ivan and I began to talk, and really, because I've been very focused, I've been in the nonprofit world my whole career, and I really wanted to kind of step away from that world and think about what people in the community really want. And we began to explore the idea of building an internal cohort of informal community leaders who could be a beacon of hope and a resource for where they live, work, play, and pray. And to really build up the leadership in the communities, the different marginalized and disenfranchised communities, no matter how they define themselves. So St. David's Foundation brought us network weaving, and we had 20 people go through the 9-month training, really learning about how to make the change they want to see in their own community. And doing that by using their own networks, their own power, and how they can network with others and find people who care about with shared vision to make change. We're now in a process of doing little seed grants from $500 to $2,000 to help people live this dream and experiment with what it means to make community change. One great example of that is women who are doing online mentorship for young women of color, and it is fabulous. And who knew that that was an idea that a couple of our network weavers had, and before you know it, they're off and running. And then we began thinking there's this one foundation here that has been investing in community resource centers, and she kept saying to us we were kind of like a community resource center. And so we went to see it, but it was a building, right? It's just a building, and we were like, what if we did a community resource center, but we utilize these informal leaders in the communities where they live, work, play, and pray, and we help them engage in the community, and we engage other members in the community. So we ended up Episcopal Health Foundation and St. David's really had a wonderful conversation together about what this could look like and how it could really help both of those organizations. We partnered with Texas A&M University, our extension agent here, to help begin to execute it. We've, St. David's paid for the first cohort of training of master wellness volunteers through Texas A&M. And we chose the advocates. We chose family advocates out of Head Start, so that because they were bilingual and they lived in the marginalized communities we really wanted to focus on. And so we ended up, the foundation of this is a volunteer engagement platform, which we had just begun to launch. when COVID-19 hit. And it was just this pivot. We went from having coalition meetings in person to having Zoom meetings. The county immediately went into our disaster response mode. We have had 8 federally declared disasters in the last 9 years. We've had fires and floods and tornadoes and all kinds of stuff, and now we've had COVID. They started their emergency command post. The chief medical officer who was assigned to that called me and said, "How can I help? You've got to help me." And because of all the work we've been doing and what St. David's had been doing, we already knew all these retired people in the community, retired public and community health people that came out of the woodwork to really surround our group with excellent public health and community health expertise. And then they asked Bastrop County Cares if we would, the county had prioritized seniors as a population. And so to make it long story short, we set a very quick task force together. We created, in partnership with Texas A&M, a distribution to be able to distribute food to the homes of people where they live, to seniors and owls where they live. And we did this by mapping in partnership with the Area on Aging. They mapped where the seniors were, where the minority seniors were, and where seniors with disabilities were. And we were able to really, I think in a very, very quick period of time, be able to provide immediate relief to those folks who needed help the most. Our next big steps, we'll be looking at broadband because it looks like all of our school children have an opportunity over the next fall and winter to be back home again as COVID revisits us. We have 112 cases currently in Bastrop County. Thank you so much, and I will turn it over to Darren Anderson.
Great, thank you. Can everybody hear me all right?
Yes, indeed.
Okay, so thank you so much. I'm really honored to be invited to present and to talk with all of you today. And I think, what I'd like to try to do is give a little bit of perspective on what's happening in the doctor's offices now and what changes COVID has brought about, and I think what opportunities it's presenting for us. If I could have the next slide. I direct the Weitzman Institute. It's a research center focused on meeting the needs of underserved populations. I am a primary care doctor myself by background and training. I'm an internist and have worked in a federally qualified health center for my entire career since residency. And from the day that I came out of training up until maybe a couple of months ago, what I do or did hasn't changed very much. It's largely built around sitting in an exam room, seeing patients, examining them physically. We did change to having electronic health records, but the general way we manage patients, brought them back in follow-up, it hasn't changed, probably going back for decades. If I could have the next slide. And unfortunately, that primary care model, based on the face-to-face encounter, had several challenges before COVID-19. There was limited access, and particularly in rural communities, good or really any primary care can be very hard to find. Behavioral health, even more challenging, and specialty care in many ways most challenging of all. We know that in the middle of Midtown Manhattan, there are plenty of dermatologists and surgeons, but as you get into more rural communities or even smaller towns and communities areas, getting access to really for minority populations was challenging. And a lot has been the high cost of the care delivery model that we've until now. Healthcare expenses increasing efforts, increasing moves towards cost share, putting more of the cost burden onto patients, and particularly in rural locations, travel time, delayed, deferred care, difficulty getting in to be seen, long wait times, et cetera. If I could have the next slide. And then on top of already system, we had COVID-19. And really almost overnight, the COVID-19 pandemic transformed everything. And at least in the short term, and I think really right up until the present time, it has knocked our system on its heels. Primary care practices had limited ability to engage in telehealth before COVID-19. and that weakness has now really been exposed bare. Really only emergent and COVID-related care is being provided. Most primary care practices have deployed their providers either home or are providing limited telephone-based care and engagement, but it's really been limited, and all non-essential care has been deferred or delayed. And many primary care practices, especially smaller ones that don't have strong financial support, are closing. And there's a lot of discussion nationally about what this will mean for the primary care workforce that already was inadequate. As the impact of COVID continues to be felt, many of those practices may not be able to reopen. And this is largely because our system, one of the challenges that I pointed out, our system was really built on the face-to-face encounter. And although there's been a lot of opportunity, a lot of movement towards developing what they call value-based care, shared savings, shared risk, these sorts of things, the vast majority of doctors around the country get paid for seeing people in person, and they get paid for doing things. And that really has exposed one of the most profound risks to the system is now that we're challenged to provide care to these patients in different ways. Many of our health centers, even our federally qualified health centers, aren't getting paid because they're not seeing patients. So fortunately, CMS stepped in early on in the epidemic, and most states have followed suit and implemented emergency modifications to our reimbursement rates that allow health centers to and providers to get reimbursed for telephone and telecare. And that has literally transformed our system overnight. To think that patients would never accept or adopt telehealth. We struggled ourselves for care to do so. My health center in the space of a week converted from doing over 3,000 visits per week in person to doing over 3,000 visits per week by telehealth. And we cobbled together a teleconferencing platform, utilized our electronic health records, sent all of our doctors home, and started seeing patients virtually. And we've been refining that system ever since. Over the last week, we've built in behavioral health, but really had to be nimble and flexible to get that up and running. And we've seen just an absolutely unprecedented adoption of telehealth, something that we've been, I guess, hoping for in many ways for over a decade, literally happen overnight. And those changes in state and federal and commercial reimbursement were essential for allowing that to happen. The other thing that happened that made this easier was many states relaxed their telehealth licensure regulations and allowed some of this activity to occur across state borders, which was important for us as well. I could have the next slide. So we're really in the midst of obviously a challenge, and not to in any way diminish, how serious and I think ominous COVID-19 is. The impact on life, morbidity, and mortality is extensive. But as I said, it really has dismantled our entire primary care delivery system and given us an opportunity to rebuild it, and hopefully rebuild it in a way that's better than it was before, in a way that eliminates or reduces healthcare inequality and inequality of access based on whether you live in a rural location or not. And so I think the message that I really want to focus on is we have an opportunity, and I think grant makers and funders have an enormous opportunity to stimulate and encourage the development of new models of care. We've broken apart the system, and now we need to rebuild it, but rebuild it better than it was before. And it has to be built on a strong primary care infrastructure, linked with the larger healthcare ecosystem, using new communication tools. Many of the things that we've been doing for decades in person never needed to be done in person, and I'll show a few examples of that. Next slide, please. So advanced primary care is what we need. And advanced primary care is really a term that reflects a primary care practice that's team-based. It can be in person, but it also has extensive telehealth capabilities so that patients can connect with you virtually, especially for follow-up and things that don't require laying hands on the patient. PCPs need to be supported by a team and enabled to really practice at the top of the license, less paperwork, more management cases, and really incented less by volume of visits and more on the quality of care that they're delivering, and using home monitoring tools to help us keep in touch with patients. All of this was possible before COVID, and now seems even more so as we build the system back together with these new components. Next slide. So The community health center where I've spent my career was founded in 1972, and I think we spent 40 years developing what you see in front of you, essentially a comprehensive integrated care team that ensures that every patient, whether they're insured or uninsured, Medicaid, commercial, when they get seen in their local community health center in their town, has access to medical providers, behavioral health providers, nutritionists, a dental hygienist, and a team of nurses that are supporting them and engaging them. And, we call this the care team. And it's something that we've taken an enormous amount of pride in. If I could have the next slide. Now that care team is having to reinvent itself and figure out how to do all of those things by Zoom. And that has presented enormous challenges because, like I said, we spent 40 years figuring out how to provide all of those services in an integrated, choreographed manner that allows the patient to receive all the services they need when they come in. But it's only been a month, and already we are seeing medical assistants serve as what we call technology concierges, engaging the patients prior to the visit to help them through any technology issues they have, and then to collect questionnaires and surveys and home-based, home-monitored vital signs. We've seen our behavioral health teams conduct Zoom support groups for stress and depression, and our nurses performing complex care management on the phone, and keeping in touch with patients and following up on diabetes and things like that. But this is all happening on the ground right now. And, our health centers are kind of winging it. Nobody's told us how to do this. And, the creativity and the impetus to make change, is absolutely critical. Can we advance to the next slide? And as we rebuild that primary care system, we continue to face challenges in getting access to the specialty care system. And access to specialists in rural locations and urban, but rural in particular, was an enormous challenge before COVID, even more than primary care. And the way I've come to know Abana and to provide some services in Baxter County was through their effort to provide better access to uninsured patients for specialists. And we know that over the last several, probably 10 years or so, the number of patients in primary care that need a specialist has gone up substantially. Up to a third of all the people that we see in a primary care practice get referred to a specialist. If I could have the next slide. But right now, with COVID, there are no specialists providing non-urgent care, very, very few. And so we had an access issue before there was COVID. Now we have an access disaster. And we knew that up to 45% or more of those face-to-face visits with specialists never needed to happen. They didn't need to drive 3 hours into Austin or wherever they needed to go to be seen face-to-face when the primary care provider had an EKG and a question about what would be the most effective next step. Or the patient had a rash and the primary care provider wanted the dermatologist to take a peek at it and confirm whether or not they thought it was scabies or something different. There's so many examples of specialty referrals that we make that could have been accomplished with a simple connectivity between the specialist and the primary care provider without the patient having to drive, figuratively and literally. Next slide, please. And what we saw even before COVID was that this interface between primary care and specialty led to wait times, having to take time off, a lot of duplication, increased cost, deferred care, and a lot of that was preventable. So the last piece that I want to leave you with, if I could have the next slide, is we've been exploring, and you can click on it twice more. There's an animation that I built in here. There are other ways to get access to specialty care. You can provide access to specialty care virtually. Communication, electronic communication between specialists and primary care, something we call e-consults. Another type of video conference interaction where a team of specialists provides video conference connectivity with a primary care provider. These are tools that collectively we can deploy regardless of where the primary care practice is, whether they're in the most rural location in Wyoming or whether they're in downtown New York, ways of connecting primary care and specialists using technology. If I could have the next slide. We call the video conference connectivity Project Echo, and we've deployed in Texas and many other locations, just about every state in the country, connected primary care practices with teams of specialists to guide them in complicated topics like pain management, medication-assisted therapy for opioid use disorder, hepatitis C and HIV management. And the primary care providers joined by video. They present and discuss their cases, and the team of experts gives them advice and guidance that they then can deploy and implement in their own practices. And if you could advance to the next slide. And confirm that our eConsult solution, as I've been kind of referring to, connects the primary care provider and the specialist electronically so they can chat and talk about cases, get advice and back and forth, and determine whether a face-to-face visit is really needed, or if I could have the last slide, or the specialist can communicate with them by computer. And by combining all of these different tools, we're finding there are many, many ways to connect that specialist and the primary care provider that really don't require face-to-face engagement, so that you can, when a patient really needs a face-to-face, you can devote the resources that you have available and the time that it takes to get there only for those cases that need it. And so I think what I'd like to really leave you with is a frontline perspective on obviously a challenge and a national tragedy and many terrible things happening to people around the country. But the silver lining in this otherwise really dark cloud is that we primary care providers and practices are in the midst of reinventing ourselves, and things that we didn't think were possible have now come true. And not just telehealth, but reimagining the way our care teams work together and utilizing some of those communication tools to help us connect in different ways is going to allow us to make for a better and a more efficient healthcare delivery system, and one that isn't going to be as prone to healthcare inequality and inequalities based on geography. Technology and the tools that I've described help to do what I like to describe as making geography irrelevant. I love it when we have a video conference, Project Echo, and we have practices from rural locations connecting with urban, and everyone's talking and sharing ideas and talking about the same type of people, the same type of cases, and it really helps us to realize that geography really can be irrelevant if we can utilize some of these tools. And so my plea for everybody on this call is to really look for opportunities to fund and support these types of innovations. We don't need a lot of new fancy technology. We need to figure out the way we can use the technology that we have now and rebuild the system in a way that will help to improve outcomes for everybody in the country. And with that, I'll leave you, and thank you so much for the opportunity to talk with you.
Well, thank you so much. Obviously, we have had a wonderful set of presentations here. And at this point, we're going to need to move to asking each of our speakers to give us their final word of wisdom. So, Alan, let's start with you.
Alan, there you go.
Yeah, thanks, John. Leave us on mute for a second, but yeah, just concisely, I would implore funders and funder friends who are on the call to really advocate for your rural communities, and that rural philanthropic dollars be devoted to your rural communities in ways that are both general, but also really reflect the way that these communities need help. That could be through your state funder association, your regional or your national group like a GIA, blog, present. This GIA webinar is one of the few that is focused on rural in the midst of all this COVID-19 activity, and particularly around equity considerations. Yeah, please talk about this every day.
Thanks so much, Alan. Abena, how about for you?
Thank you, John. 3 key points: flexibility in terms of who, what, how we fund, and also an expected focus on health equity, since this crisis has really elevated the need for equal health justice in the communities and now funding. And the third thing I would like to mention is the importance of building community capacity. So if we support marginalized communities, rural communities, to build their capacity, yes, they will step up to the plate and create solutions to address the challenges they encounter. Thank you.
Debbie, how about for you?
I'll be very quick. I think that this is a time of innovation where we can really think about how we do our world differently and make the changes we've wanted to make for a long time. And I think to do that in partnership with philanthropy and the communities that's wanting and needing that change, we can make a huge difference. Thank you.
Thank you so much. Darren, final word for
Yeah,
you.
I would say exactly the same thing that Debbie had. The only thing is don't underestimate how stressed and challenged the primary care practices in general are, but particularly primary care practices. As much as we have huge opportunities to rebuild ourselves, there are many practices that may not make it to that point because of the immediate need for support. And so I think it's important also to look for short-term opportunities to shore up that primary care infrastructure to allow us time to reinvent ourselves in a new way. Thank you.
I want to thank Alan Smart, Abhina Asante, Debbie Brissett, and Dr. Darren Anderson for their wonderful presentations this afternoon. We thank you for all you do to help support those living in rural areas and for older people in general. We also want to thank the Johnny Hartford Foundation for their continuing support of this webinar series and this webinar today. We will be making today's presentation available to anyone who wishes to view it later, including both the slides and the audio. Please watch for an email to be sent to you in the next few days. And finally, I want to thank all of you for participating in today's webinar. Please stay safe.